by Dennis J. Courtney, M.D., Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724-942-3002. That's 724-942-3002 for Dennis J. Courtney, M.D.
Good morning, everybody. Good morning, everybody, and welcome to AM Impact on Your Health. AM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AM Impact on Your Health, heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, and fascinating health topics. Also, of course, where we do encourage you to call in to join in. Today, well, folks, we're going to be, officially launching a new program, a new protocol here. Today is the first in a series. We usually do this, by the way. We put the full force and enthusiasm behind our efforts here, all in one big splash. And then we'll give you updates as to how things are turning out as they move along. But a new topic has entered the scene, not a new disease, but a group of patients that I keep seeing over and over again, a dastardly disease affecting a lot of people. It's called peripheral neuropathy. It's found in diabetics in particular, but not exclusively. But this thing called peripheral neuropathy causes a great deal of angst, a great deal of symptoms, great deal of loss of function. And now that we know, and I hope I'm able to show you in these next few shows, that you actually can reverse this disease now, and we'll give you the objective evidence to prove that, I hope you'll string along with it and walk down the road as we start to learn this new protocol together. Today, fortunate to have one of the investigators, lead investigators of the objective findings of this reversal. His name is Dr. Alan Jacobs. He's a podiatrist. He's a foot doctor. Who better to know the ravages of peripheral neuropathy other than a podiatrist? Anyway, he's also not just a podiatrist. He's a lead investigator on a study that we're going to be talking a lot about today, showing you how, in fact, peripheral neuropathy gets reversed, objectively prove how it gets reversed, and we'll be adding to this particular approach as the week moves on. So today, Dr. Alan Jacobs, our guest today, coming to you from right out of surgery. Just got off the phone with him on his way to the office. He had surgery already this morning. My goodness gracious. Okay. Of course, if you want to call in to ask a question or make a comment with Dr. Jacobs, you may do so, as always, by dialing us up at 412-825-6262. That's 412-825-6262. If you have symptoms of numbness of the extremities, lack of sensation in the extremities, pain, aching, tingling, numbness, the list goes on and on. You may not have been diagnosed as having peripheral neuropathy, but you very well may have the beginnings of it, and you want to pay attention today as we cover this topic, hopefully in its entirety. Now, on Wednesday, talking about the rest of the calendar, we're going to have part 2. Another doctor is going to join us. He's not a podiatrist, but he's been working and specializing in the treatment of peripheral neuropathy for a lot of years. He'll be coming to you from Chicago, Illinois. His name is Dr. Jason Huey, and he'll shed a different perspective on the treatment of peripheral neuropathy. As you will see, a protocol is emerging. We'll finally put the topping on that one when we pull all these investigators and experts and listen to them and how they've been treating it and the kind of results that they've been getting, and we'll let you know how our particular program is going to go here. I think it's unique. I think it's a one of a kind. I don't think I've seen any evidence of this kind of approach that we'll ultimately be taking here anywhere else in the country, and that, well, it just suits me fine. Okay, the month rolls on. We'll have, MCG testing, by the way, back out of Monroeville. MCG testing is going to be there on the 20th. If you are, maybe you're going to be out there shopping, going to be in the area, you got about 10 or 15 minutes to kill, as if you need to kill time out there at Christmas shopping. Nonetheless, we'll be at our Monroeville office on the 20th doing MCG testing, multifunctional cardiogram, determining the status of your coronary arteries in a completely unobtrusive atmosphere. No threat, no risk, no side effect, no consequence other than the sheer knowledge of what the status of those arteries are, because we never want you to have. The way you really find out is by having a cardiac cath. Now, who would ever want to have one of those? We can get the same information in this electronic wizardry way of, we call it MCG testing. Many of you have taken us up on this offer. Many of you have found out the status of your arteries and are working to make changes in them, which is another good part of this test once you know where you stand with respect to your own disease and your own degree of pathology. How to get that turned around and improve these scores is what really should the medical approach should be all about. That's what we're all about here. And got to know exactly where you stand before you know how to assess where you will arrive once you put a plan into play to make those corrections. Okay. Just even looking off in the future, I look into January. We already got Susan Smith-Jones. She's not only booked for January. She'll be here in the month of February, too. January 4th, February 1st, Susan Smith-Jones. We have no idea what the topics will be, but she will be our featured guest on those dates, already knowing that. We also, let's see what we have here. HCG testing, one of the most early ways of assessing whether or not a cancer is present is through the use of very sensitive testing of HCG. HCG is human chorionic gonadotropin, actually the pregnancy hormone, very familiar to us all, at least those who have went to get a blood test to find out if they were pregnant or not. But as it turns out, cancers in the earliest stages put out minute, minuscule amounts of HCG, which can be detected with sophisticated laboratory analysis and let you know whether there's a cancer present or not. If you have no idea about any cancer you may have, and you sort of like to know, geez, is it possible to know if I have a cancer in brewing? It is. HCG testing is a way to do it. If you are a cancer survivor wondering, hey, how am I doing here? I've got no reported return of any of this tumor, but I'm unsure. I'd like to be able to check to make certain. HCG testing is one way to do that. I keep referring you to the shows that we did back in October. The dates were October 10th and October 12th. Please refer to the archives. Go to the archives at djcmd.com. On the opening page, you'll find an icon marked Archives. Click on it, and a list of all our previous radio shows will come up. You want to click on the radio show for October 10th and 12th. These are the two shows we did with Dr. Emil Shandel and talking about his testing done at American Metabolic Laboratories in Fort Lauderdale, Florida, where he has the most sophisticated way of making determinations whether these minuscule amounts of HCG are present, and they should not be present in a non-pregnancy state, and he reports that he can detect a cancer with a cluster of cells as small as 12 cells, and that is a phenomenal number to think that anything is possible of even detecting. So there you go. HCG testing available here. MCG testing available here. We'll be at Monroeville on the 20th, and I will have dates for you for the month of January in both offices, both McMurray and Monroeville, with respect to up-and-coming future test dates for MCG. Okay. Now, just before we break, to set this in proper perspective, we're having an expert guest today on the subject of peripheral neuropathy. Leg symptoms are some pretty terrible things that could befall us with the advancement of peripheral vascular disease. Peripheral neuropathy, is it the nerve? Is it the blood vessel? Is it a combination of both? We're going to talk to an expert today who's done the research to show how you actually can turn this thing around. I'm not familiar with any other reported objective ways of doing this, and I'm so pleased to have our guest today to be able to speak of it, lead investigator on a recent article published on this very subject. We'll get with him in just a moment. In fact, Why don't we take that short break right now? And when we return, I hope to have Dr. Alan Jacobs with us. He's out of surgery, he says. He's willing to come along and spend some time with us today to talk about his monumental work that he's published, and we'll get into the issue of peripheral neuropathy on our return. Be right back.
This is Dennis J. Courtney, MD. Have you become confused about how best to manage your health? It's no wonder. It seems that every time you turn on the television or radio, another expert has yet another suggestion for you to follow that seems to be reasonable enough, but no matter how dutifully you follow the instruction, it just doesn't quite produce the results that you are looking for. If this confusion sounds familiar to you, give us a call at the Center for Complementary Health, where we'll make some sense of the confusion based on a blending of traditional and alternative medicine that we've been perfecting over the last 7 years. We offer metabolic nutrition testing, immune system repair, natural hormone replacement therapy, chelation therapy, cutting-edge allergy correction, and a host of other safe and effective alternative therapies.
Dennis J. Courtney, MD, is located at 3075 Washington Road in McMurray. Phone 724-942-3002.
Have you been to the doctor lately? Was fatigue top of your complaint list? Even if your doctor asked you what you eat, the recommended 5 servings of fruits and vegetables a day is a dream in your busy schedule. What if you learned of a product 5 years in the formulation that delivers 5 servings of fruits and minerals in just 1 ounce? That's right, it's Fruit of the Spirit. The blessings of Fruit of the Spirit are now formulated into a delicious whole fruit puree product rich in antioxidants and minerals. Your health is more than just a test result. It's a balance of physical, spiritual, and emotional factors. You work regularly to strengthen your faith. Let Fruit of the Spirit help cover your nutritional needs in a convenient and cost-effective ounce a day. Call 1-800-442-3793 for a special promotional offer. Fruit of the Spirit, a blessing for your good health. Fruit of the Spirit, 5 servings of fruits and minerals with no added sugars. That's 1-800-442-3793 for your good health. Call them now, 1-800-442-3793.
Good morning, ladies and gentlemen. Welcome back once again to AM Impact on Your Health. Heard here on KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney with you today on this Monday morning version of the show, launching a new topic and a new program on a set of disorders and diseases I've been looking at for a long time. Our expert today has also been doing so. His specialty leads him to confront these kinds of disorders each and every day. He's also lead investigator on one of the papers we want to discuss today, showing objective return of function and proof that you can reverse peripheral vascular disease. That's a big, bold statement. Never heard it made before. Nonetheless, this investigator ought to know. He's a podiatric physician in St. Louis, Missouri. He's straight out of surgery. He's willing to come aboard with us this morning. I want to say good morning and welcome him to our show right now. Good morning, Dr. Jacobs. Thanks for allowing us to invade your morning.
Good morning. It's my pleasure, really.
Well, look, Dr. Jacobs, I don't know how surgeries work out there, but I'm from the OR myself. You were doing surgery awful early this morning, weren't you, Doc?
Yeah, I typically start 6 a.m. and do a case or two before I get over to the office.
The anesthesia department must think you're cruel. I'm an old anesthesiologist, Doc, so imagine what kind of operating room actually has to start to get you started at 6 a.m. Unbelievable.
Well, that's okay. I'm an old surgeon. I'm accustomed to that.
Well, we could commiserate on that sometime. What you are, though, however, is a pediatric physician working with disorders of the foot, the forefoot, and the leg for a career now. And after publishing an article, which we're going to reference here in a moment, the issue of peripheral neuropathy, peripheral vascular disease, diabetic peripheral neuropathies are all synonymous terms, or at least interlinked and interrelated. Could you express to us, for a little bit at least, in your career, how often, how frequent this disorder comes to you, how the very many ways that it could presents to you, You've seen this disease each and every day of your working career, I'm sure. Spend a few moments with us and bring us up to speed on how prevalent this particular problem really is.
Peripheral neuropathy is very prevalent, and it's become a major focus of practice, particularly if you're a podiatrist or an endocrinologist or an internist, because of the rising incidence of diabetes in the United States. And many of your listeners probably know that diabetes is the leading cause for amputation of legs in this country and in the world. And years ago, we used to think this was due to peripheral vascular disease, meaning for the audience, of course, blocked up arteries in the legs. And we've come to realize that the number one risk factor for amputation in the diabetic patient is neuropathy, meaning the diabetes affecting the nerves that go to the muscles, to the skin, to the sweat glands, to the blood vessels in the legs. And it's not the patients that have painful neuropathy, because neuropathy means that something's affecting the nerves. Most frequently in the United States, it's going to be diabetes if you're going to find a disease causing this. And some people get, tingling or burning or shooting pains, in which case we encourage the patient or make efforts to get better control of their diabetes, because that's the number one thing you need to do to try to reverse neuropathy. But the real danger are the patients that have numbness and have no feeling in their feet. Because what happens is they get injuries to their foot, and it could be something like stepping on a piece of glass. It could be a foreign object in their shoe, and the patient doesn't know that they have something in their shoe. It could be just standing outside on a hot day in Pittsburgh by the pool, and you don't realize the concrete's burning your feet. And what happens, or it could be an everyday problem, a hammer toe, a bunion, something rubbing on the shoe. And if you or I had these problems, we would know something's wrong, we would feel it. The diabetic patient with numbness doesn't realize there's a problem, and so the problem continues until the skin breaks down, and there's an opening called an ulcer, and then sometimes this ulceration will become infected. And 80% of diabetic amputations, meaning where we have to remove part of the foot or even the leg, 80% of the time it is caused by an ulcer that was due to neuropathy. And the bad circulation then becomes important, because once there's a wound, the patient's unable to heal it effectively because they don't have enough blood to sort of heal that wound. So neuropathy has become a critical focus to anyone who treats patients with diabetes, and particularly those that treat diabetic feet, so that frequently the podiatrist is actually the first one to recognize the presence of neuropathy, because patients are going with various concerns with their feet, and they don't realize that they've lost feeling in their feet until it's demonstrated to the patient in the office.
Now, and this is doctor to doctor here, but I'm sure you have your own personal opinion on this disease process. And so, do you look at this? And I ask you now, as a doc to a doc, is this an issue where, in a diabetic, where we know cardiovascular disease runs rampant, that at the first step in this problem is the lack of a blood supply to an area? By the way, especially in diabetics, this would be to the microvasculature. I mean, that really is the ball game in the diabetic world, that the microvasculature is where they lose it first. And then with a lack of a blood supply, the nerve then can't function properly, and then, in fact, can wither up and literally die. And the combination of one leading to another, then finally symptoms that you would expect, make this a progressive disease, starting first with the lack of the blood supply. So I pose that to you. Is this theoretically how this disease finally gets implanted, or do you think it's something completely different? Is it a primary neurological problem found in a diabetic? Is it the nerve itself, or is it a blood supply? Is it a combination of both? What do you think?
It's clearly a combination of both. It's interesting that we can define differences between diabetic and non-diabetic nerves. So we can study diabetic nerves and say, oh, look, they lack certain substances, say myo-inositol, or they have too much of certain things, say sorbitol, or they accumulate what we call N-glycosylation products, the effects of the high glucose levels, and they lack blood supply. So we could identify differences between diabetic and non-diabetic nerves, but the actual cause still remains unclear, because if we could identify, obviously, the specific cause, then we could reverse it in every patient. What we do know is that the diabetic neuropathy starts years before the patient is diagnosed with diabetes. And we know that because there's testing we can do where we take a biopsy of the skin and literally send it to a laboratory where they could count the number of nerves in the skin. And we can show that many patients, if not the majority, the day they're diagnosed with diabetes, if you do a biopsy of their skin, they have already lost substantial amounts of nerve supply, the innervation, what we call the small fibers, the little teeny nerves in their skin, the nerves that are responsible for, say, pain perception, for temperature perception, the nerves that go to the sweat glands. We know that there's substantial loss the day that they're diagnosed with diabetes, so that neuropathy has been going on for quite some time. We also have studies where doctors have done MRIs of feet. Some of this has been done in the United States at New England Deaconess Hospital. Some of them have been done in Sweden, where they take patients the day that they're diagnosed with diabetes and do an ultrasound or an MRI, and we know that on that day they've already lost 1/3 of the muscles in their feet. So that tells us that the effects of the neuropathy, the nerves that are going to the muscles, has already been working in this patient for quite some time. So the exact cause is unclear. Certainly small circulation problems are part of this issue. There are what we call metabolic defects that also can be identified, and it's probably a combination. But the important thing for the listeners to understand is that the neuropathy precedes the diagnosis of diabetes. And so at the time a patient's diagnosed, if they're carefully examined, there's already evidence that the neuropathy has been damaging that patient's feet. The problem is most doctors are not going to spend the time searching for neuropathy unless a patient complains about painful neuropathy. If they say, "Doctor, my feet are burning at night," or they tingle at night, or I get shooting pains. And that's only really at most 1 out of 5 patients with diabetes. So at most, only 20% of patients have what we call symptomatic neuropathy. It's the non-symptomatic neuropathy that's critical.
Very good point. Now, as a podiatrist, having these types of pathologies presented to you daily over many years, you, I'm fearful, probably have to have a yeoman's effort at reversing a well-established infectious process, usually as the presenting reason for why they're consulting with you. They usually have their infection running rampant at the time, and you got to try to save the limb at all costs. And so I can imagine most of your efforts are in doing just that. I would be right about that, would I not?
That's what I was doing this morning, in fact. It was a revision of a very complex infection in the arch of a patient that had diabetes. He's a 69-year-old gentleman. He has significant neuropathy, so had a horrible infection and very little pain, in fact, no pain really, and has very poor blood supply. And we battle constantly to try to salvage legs and prevent amputations. The majority of diabetic foot amputations are preventable, and there is just published work after published work that shows that if a patient is undergoing regular examinations and people are trying to treat little problems, because the majority of amputations start as little stupid foot problems, anything from an ingrown toenail to a bad-fitting pair of shoes, 70% of amputations are preventable, 70%. And this has been studied and published in numerous studies. So we know we have the capability of saving legs and saving lives. It's a matter of patients accessing the resources to have that done. And unfortunately, even though we know that diabetes is the leading cause of amputation, we're not impacting amputation rates daily. The amputation rates have not gone down in the United States because people are not having access to detailed foot screenings, foot examinations, and then most importantly, interdicting the factors that we know are responsible for these ulcers that lead to amputation. And it's just critical that diabetic patients get that kind of care. I mean, we don't wait until a person has a heart attack. If we identify blocked up coronary arteries of significance, the cardiologist doesn't say, well, come back when you have a heart attack and we'll lower your blood pressure and we'll lower your cholesterol and we might stent a vessel or do what we need to do. They interdict to prevent a significant coronary event. And the same analogy can be done with the lower extremities if you have doctors who are looking and doing serious examinations and then recommending appropriate therapies for patients to prevent ulcers and therefore prevent amputations.
Now, you mentioned that one of the nifty objective ways of really assessing how far progressed a condition of peripheral neuropathy could have attained is the use of what's called epidermal nerve fiber density. These are biopsies you can take of the tissue and really know from the get-go, from the beginning. You mentioned on day one of being a diabetic, you do this. And if you've been doing this for a long time, is this a standard practice in the podiatry world to do these epidermal nerve biopsies? Because I'm not that familiar with them, and yet I find them to be a wonderful objective way of looking at this problem. Could you elaborate a bit on these biopsies?
Sure. Most people, when they have nerve problems, and probably the listeners would be most familiar with carpal tunnel, which is what they call an entrapment neuropathy. You see a neurologist or you see a physiatrist, and they do an electrodiagnostic study, what's called a nerve conduction study. The problem with nerve conduction studies is that they measure the large nerves in the hand or foot. And diabetic neuropathy starts with the very smallest little nerves, and the most sensitive test to diagnose neuropathy, even though a nerve conduction study may be normal, is this epidermal nerve fiber density test that you're speaking about. Now, the epidermis is the very top layer of the skin, and this test is shallower than, for example, when you, say, shave in the morning and you accidentally cut yourself. You actually probably go deeper with that than you do with this actual biopsy. And this is a 3-millimeter skin punch, so it's basically the same device that a dermatologist uses to sample skin lesions to tell you what's wrong with your skin. It's done under local anesthesia in the office. It takes maybe a minute to do. And what we do is we get a 3-millimeter sample of the very top layer of the skin, the epidermis, and that is sent to specialty labs because not all laboratories do this test. And what they literally do is count the number of nerves in that 3-millimeter piece of skin. And they can tell you whether you have normal amounts of nerve in the skin or whether you already have lost what are called the small nerve fibers. And these are very, very important because, as I mentioned earlier, these are the nerve fibers that, for example, pick up pain sensation. So when you lose these small little nerve fibers, this is how diabetic patients injure themselves, and they don't realize that they've injured themselves. They also are the nerves that go to the little blood vessels and sweat glands. And this is very, very important because everybody knows that treats diabetic feet that diabetics have very dry skin. And the reason for that dry skin frequently is loss of innervation to their sweat glands, what we call autonomic neuropathy. Now, you might say, well, what's the big deal about having dry skin? I'll just go get a lotion. Well, there's two big deals about it. The first is that it causes problems in the foot itself, cracks and fissures, and people pick up athlete's foot, and then they get secondary bacterial infections. But more importantly, I think, is what it represents. 75% of patients that have peripheral autonomic neuropathy on this little skin test also have evidence of cardiac autonomic neuropathy. And these are patients that are prone to significant issues with silent heart attacks, what are called silent myocardial infarctions. They have left ventricular problems. They have exercise intolerance. So very frequently, that loss of little teeny nerves that you pick up with that little biopsy in the foot is actually reflecting a more generalized problem. The patient probably was not having symptoms, complaining about issues to their internist or their primary care doctor, and it leads to referrals to cardiology and interventions before something serious happens to the patient generally. So it's actually an opportunity at times for that podiatrist to not only save a leg, but to actually save a life.
I think that if we are talking about the diabetic, you and I would be both well adept at saying how all-inclusive, literally, there's not one single zip code in the body that's spared when it comes to the ill effects of diabetics, the consequences they'll face. If you're working on the foot very far south, you could expect everything north of the equator all the way up to the heart and brain. They've been affected too. Interesting that you've seen this relationship between diminishment of the number of nerve fibers in the skin of the foot foretell the level of pathology to the real big organs upstairs, like heart and brain, and that you probably have a common referral pathway between yourself and your local cardiologist because of this tie-in, huh?
Oh, yes, and this is nothing new. Many of your listeners have probably seen the commercial on television for peripheral arterial disease, PAD. And you have a commercial where they tell you on television that if you have pain in your legs when walking, something called claudication, that frequently the bad circulation in your legs is reflective of the coexistence of bad circulation in your heart or this vessel to go to your brain or your kidneys. And so we know that patients that have bad circulation going to their feet very often also have bad circulation to their heart. And you could actually refer these patients back, and it turns out that they had undiagnosed, because it wasn't, say, bad enough to cause symptoms yet, coronary artery disease. So, and this was a very well-known study called the Partners study. I actually got to participate as one of the researchers in that, where we measured the circulation at the ankle in patients, and then had the patients worked up systemically and showed that this was reflective of other issues. And it's the same thing with neuropathy. Patients that have small fiber neuropathy in their feet, particularly autonomic neuropathy, very frequently have other issues. It could be, with regard to autonomic neuropathy, it could be erectile dysfunction. It could be problems with diarrhea or constipation. It could be difficulty emptying their bladders. It could be patients who tend to get dizzy, what we call orthostatic hypotension, when they're lying or sitting down and stand up. It could be patients that have rapid heartbeats. But the point is that oftentimes, and I don't want to make this overly dramatic now, but the truth is that very frequently vascular disease in the foot or neuropathy of the foot is part of a more generalized problem that needs to be investigated by other healthcare providers, whether they're primary care or internists or cardiologists or whomever. So very frequently, again, it gives us the opportunity to find patients and refer them back to other healthcare providers who then intervene before something very bad happens to people.
Now, I'm going to swing this discussion a little bit to the side that I think, I'll express what my general overview of this has been, and then I'm going to bring in, I believe, the real beauty of your work. First ray of sunshine I've seen coming through this window in a long time, actually correcting, reversing peripheral neuropathy, and it can be done, folks, and this gentleman ought to know. But would you say in your career that although you fight infection a lot, and most of your job is trying to make sure a little thing doesn't become a big thing, that with respect to returning around peripheral neuropathy, this has been a daunting task, has it not? This has been a very difficult task, if not an impossible one. Share with me your clinical impressions on that ability to reverse this in the past, Because I haven't seen it. And if you have, please let me know.
Of course, now your listeners have to keep in mind that when we talk about neuropathy, just again, we're talking about two different things. One are patients that have painful symptoms with their neuropathy. So they say, I can't get a restful night's sleep, this type of thing. And the other are the patients that have lost feeling or lost nerve supply to their muscles or lost, say, sweat function. They're two different things. When people have painful neuropathy, of course, there are medicines that are given to try to reduce their symptoms. But the difficulty has been the patient who's lost feeling to their foot. And the first thing we tell patients to reverse neuropathy is you've got to, number one, stop smoking, control your cholesterol, control your blood pressure. All these things are critical. It is extremely important, in fact, number one, to control their diabetes properly. And it's very difficult to reverse neuropathy symptoms when patients are doing a poor job of managing their diabetes. Now, with that said, all other things being equal, reversing neuropathy can be done several ways. One way is some patients have literally entrapped nerves in their feet and legs. They have, it's sort of analogous to carpal tunnel, and if a doctor finds evidence of these trapped nerves, sometimes surgical release of those nerves is helpful. Our research has been using active forms of high doses of vitamin B, basically the active form of folic acid, which is called L-methylfolate, using the active form of B6 and B12. And what we did was take patients with diabetes, do baseline epidermal nerve fiber density studies, count the nerves in their skin, then give them L-methylfolate, B6, B12 by mouth twice a day. And in about a third of the patients, we were able to show that a rebiopsy indicated that nerves were regrowing in the foot, that they actually were able to reinnervate their foot, so that you had some patients, I wish it was all, but some patients who regained feeling in their feet. And other testing and studies have been done. There's a fellow in North Carolina who actually did testing on patients' ability to detect vibration in their feet, for example. And this was a computer-based testing system. It's called quantitative sensory testing. And he did the same thing, administered L-methylfolate, B6 and B12, and was able to show that patients gained back the ability to detect two-point discrimination, vibratory perception, and more recently, work was just presented showing how this improves quality of life and reduces the frequency and intensity of symptoms. So not only can we take some patients with diabetes and actually show increased innervation of their skin, but we also can show that this leads to improved quality of life. I wish I could tell you it was 100% of patients. In general, our work that was histology-based, so that this was not subjective, was totally objective. On average, we were able to double the nerve count in the skin of feet in patients with diabetes just by administering L-methylfolate and active forms of B6 and B12.
That is a big thing that you came across. I'm looking at the monograph right now. I want to commend you and your co-author, Dr. Chang, but the first time I've seen the print where actually you can objectively, and I use the word objectively, quantify reversal of peripheral neuropathy based on a nutrient. B12, B6, and folic acid, well-known nutrients. We take them every day, yet you use them to get, you say, it was a small study, 11 patients. However, of that 11 patients, 73% of them got an increase in the epidermal nerve fiber density, 73%, and you said that 82% of those 11 had a decrease in either paresthesias, which is sort of the numbness form, or the dysesthesias, which is sort of the painful form of the peripheral neuropathy. Those are monumental findings, my friend. Wouldn't you agree?
I like to think they are. I can tell you that we've had wonderful luck with many patients, and it's kind of interesting because there's a tendency at times, I think, because of all the medications we write for in today's world, to sort of poo-poo, if you will, nutritional efforts at resolving many problems. And it's not a poo-pooing at all. I mean, look how common, for example, it is for patients now to be treated for vitamin D deficiency. I mean, look at all the patients that see their primaries, and they're told you're having cramping or you're having certain symptoms from vitamin D deficiency. And years ago, of course, we had a big push on, say, vitamin C deficiencies. So it's kind of funny because we tend to not think of high dose vitamin therapy as being very, very helpful, but we know there are clearly mechanisms of action. For example, in using L-methylfolate B6, B12, we know that it is helpful in increasing circulation to the nerves and other parts of the body because the L-methylfolate stimulates our bodies to produce a substance called nitric oxide, and nitric oxide opens up our blood vessels and increases blood flow. So we think that perhaps one way this is helpful is increasing blood flow to the nerves. We also know that L-methylfolate, the active form of folic acid, B6 and B12 are needed to get rid of an amino acid, a chemical in our bodies that we really don't need. It's not essential. It's called homocysteine, and homocysteine is a substance that lowers circulation to nerves, lowers circulation to wounds, does have some cardiac implications. So we know that high-dose vitamin B therapy does have some explainable mechanisms by which it could be helpful for neuropathy. It increases blood supply. It lowers the level of homocysteine. We know that patients that have diabetes and neuropathy tend to run higher homocysteine levels than patients who have diabetes without neuropathy. So not only have we seen direct evidence that some patients will regrow nerves with the use of L-methylfolate B6, B12, we could explain it. We have mechanisms to explain how it's actually worked.
Outstanding. Now, this, of course, is a study that you ran. This was a 6-month study that you started this group. You took the 11 folks. You got the epidermal studies done, and then 6 months later, after daily administration of B12, B6, and folic acid, you got the stats that we referred to. The 73% that showed increase in growth of the numbers of them, and 82% that showed an increase in, or the improvement in symptoms. Up until that point, as a podiatrist, confronting peripheral neuropathy every day, have you ever come across anything that could provide you those kinds of results? I'd like to know. Do you, or have you?
Well, we wouldn't know because we had not done any epidermal nerve fiber density testing.
New. Okay, so nerve fiber testing has been relatively new. So we can only take subjective improvement before you did this study. Did you find any modalities that you used, or combinations of them, that could provide you with, well, you said 82% had symptom relief of some type. Anything like that going on with anything else you were doing other than nutritional?
Well, we did have symptom relief, and we used standard drugs. And for the listeners, again, for the 20% or so of diabetic patients whose neuropathy is painful, we tend to use drugs that run the gamut from antidepressants to medicines that traditionally were used to treat seizures or partial seizures, to some newer agents that are called serotonin, norepinephrine reuptake inhibitors. We sometimes use pain medications. There's tramadol, for example, is a pain medicine that is sometimes helpful. So we would have patients that came back and said, my symptoms are better, but we weren't really treating the underlying disease process. So it's one thing to treat symptoms, it's another thing to actually treat the actual disease. And the L-methylfolate B6, B12, we know, enables us to reverse the actual neuropathic process and in some patients actually increase nerve count. When we give these other medicines, and there's nothing wrong with giving them now, I write for them all the time, the gabapentins and the nortriptylines and the amitriptylines and things like that, we know the patient may get better symptom relief, they may sleep better, have less shooting pain, but we're not doing anything to stop the actual disease process. And the other thing is we're only treating the sensory part of it, the painful part of it. And much of the damage that's done in the diabetic foot and diabetes in general, an example would be, say, as I mentioned earlier, say diarrhea or constipation, that type of thing. These are things that have nothing to do with pain. It has to do with the autonomic nerves. It has to do with the motor nerves. And so nutritional therapy, together with control of diabetes, offers you the opportunity to reverse these non-painful but very important manifestations of diabetic neuropathy.
And to just pick up, because now I think you've really stumbled across it, you can get symptom relief. All of allopathy is based on writing for a drug to get symptom relief, none of which really improves the pathology that brings you to the table, so to speak. So now you bring in a nutritional therapy that for the first time, and admittedly now maybe you didn't have epidermal testing before, you certainly got it now, but I think you even took that to the step. You've surmised that when you were writing for the scripts, and maybe you still do, and you're getting symptom relief, you were not affecting the primary pathology. It raged, it went onward, and it was only until nutritional interventions occurred where you actually got a major turnaround. That is monumental. That is a monumental study. I hope you're being lauded for it by your co-professionals, because I certainly applaud you for delving into something that brings us a way to concretely reverse peripheral neuropathy and objectively prove that the changes have occurred.
Well, it was nice when epidermal nerve fiber density testing became readily available, because it's done in the office. It's one little stick with a 27 gauge needle, so it doesn't really tie anybody down. As I mentioned, it's the top layer of the skin. And what's nice about epidermal nerve fiber density testing is that it gives you a way to see if your patient is responding to treatment. And if not, you can move on and try some other nutritional aspects, because to reverse numbness or reverse the effects of diabetic nerves affecting the muscles, loss of muscle function, and again, non-painful neuropathy, you're not going to write for pain-killing medications. It has to be control of the diabetes and something to make the nerves healthier. And short of using, say, nerve growth factors or things like that that are still experimental and very expensive and really only available on a limited basis, nutritional therapy is the answer. And if you go to standard reference centers like the Cochrane database, this type of thing, you find that this is really not a new concept. For example, methylcobalamin, vitamin B12, has been used for a long time for the treatment of neuropathy, and there's numerous papers showing it is also helpful in alleviating not only the symptoms of neuropathy, but restoring, for example, nerve conduction velocities, meaning it improves the function of muscles in some patients. So it's not a new concept. And numerous nutritional agents, if you want to call them that for lack of a better term, I like to use the term neurotrophic. Maybe that's not a good term, but things that make nerves healthier. For example, inositol, 500 milligrams 3 times a day is helpful.
Inositol exercise, a form of niacin, I think you mean, correct?
Yeah, and L-carnitine, up to 2 grams a day, has been shown to be helpful. So I don't want to imply that it's just L-methylfolate, B6, B12. We've had wonderful success with that particular agent, but there are other nutritional agents that have been shown in the literature, in decent peer-reviewed literature, to be helpful for some patients with symptomatic neuropathy. But above all, number one, patients have to manage their diabetes properly, manage their hypertension, manage their lipids and triglycerides and all this type of thing. Otherwise, they're just wasting their time frequently taking these nutritional supplements, whatever they may be.
Now, could I ask you a bit, because my listeners absolutely want to know when it comes to nutrients, and these three in particular. What kind of dosages are we talking about here? Of course, these are all sold over the counter. They can be easily enough handled by you. Just the listener walking in to their health food store will say that the federal government does regulate the amount of folic acid that's allowed to be dispensed per capsule to, I think, 800 micrograms, if I'm not mistaken. And so I'd like to try to get an idea of the dosages that are involved when you did your study and when you prescribe this every day to the patients you treat now. What kind of doses are we talking about?
Well, I don't want to comment actually on the dosage. I think that's being looked at again. I was using a proprietary mixture of L-methylfolate, B6, and B12, and I don't really recommend personally over-the-counter dosing, and I'll tell you why. The folic acid that people take in their diet every day has to be converted to an active form. And that active form requires the folic acid to undergo 4 separate, I'm going to call it isomerization steps. And not everybody has the ability to do that. So there are some people who ostensibly have a diet with an adequate amount of folic acid, but they're unable to convert that into the active ingredient. So if they take a look at the paper that I published, and you probably have it there, I would
Got
say.
it in front of me. Mm-hmm.
Yeah, I have the proprietary dosing there, and that's really where my research was sort of based, and we're sort of looking at that again to try to come up with, I think, the ideal dosage.
Well, you had them taking one tablet twice a day of the proprietary form, correct? They took twice a day. They took twice a day dosing over the 6 months. Of course, I'm well familiar with the proprietary substance you're talking about that actually is sold in prescription form because really of the kind of and the amount of folic acid. That's a tricky one. That's the one that over the counter is tough to duplicate. So you mentioned folic acid and the isomerization issues. I'm not that familiar with it. The fact that it's this conversion that has to be undergone. But you're saying the proprietary form, that kind of conversion is avoided? Is
right. Well, the proprietary form that I use has 3 milligrams of L-methylfolate, 2 milligrams of methylcobalamin, and 35 milligrams of B6, which is pyridoxal 5-phosphate. Okay, that's what I use. And again, the reason I do this is because they and I'm not sure this is true. I'm not sure the numbers are exactly there, but somewhere between 30 and 40% of people in the United States have an inability to convert folic acid to the L-methylfolate, which is what's necessary to do the things we talked about. When you give a proprietary prescription strength form of this medication, which is now available generically, by the way, you bypass the need of that person's body to make that conversion. And so you know that they're getting what they need. So I don't know how to recommend a dosage of over-the-counter B6, B12, or folic acid, because people can take large amounts of folic acid, but if they lack one of the what are called isomerases necessary to make that conversion to the active form, they might as well not take any folic acid. They're not getting the benefit of it.
Well enough said in terms of trying to do this on your own when the proprietary form has the L-methylfolate form, the form that needs to be the active ingredient anyway. To get there on your own, some people just can't do it, and you don't know who you are to try to do this on your own. Easy enough done with a prescription item, a proprietary form of the 3. So the studies, what are you into now? I'm guessing that this was as exciting to you to be able to publish as it is for me to be able to read. But what are the next steps for Dr. Jacobs? What are you doing right now, Doc?
Well, I'm actually continuing the same work. We have a cohort study now that's we're well into 300 plus patients. And basically my passion has remained diabetic foot. Honestly, when I started practice, I'm from Philadelphia originally.
I can tell.
And
I can tell, by the way.
Can you?
Yeah.
It's not a good time to be an Eagles fan, but
okay.
But in any event, when I graduated in '73, diabetes was not a big part of podiatry practice, and we were loath to get involved with any diabetic patient for fear of complications. And now, diabetes has become such a huge part of our practices that has sort of overwhelmed my practice, and my research presently is in not only the area of neuropathy, but trying to expedite healing of diabetic ulcers and diabetic wounds once they occur, because the longer a person has an open wound, the more likely they will get some complications such as an infection from that. And this has become a big issue in the medical corporate world also, so we've been looking at various products that are available to try to expedite healing of ulcers and get them to resolve before infection sets in.
Well, maybe one time in the near future we can come back to you and find out how you're coming along with your next study. I will say, I tip my hat to you for the study you've already done. It is monumental, and I hope you're being recognized for it as such, Doctor. Thank you very much for coming aboard today. We got bongos in the background. This means it's our time out of here. We thank Dr. Alan Jacobs for spending time with us today. We'll be with you on Wednesday talking more about peripheral neuropathy. Until then, this is Dr. Dennis Courtney with Dr. Alan Jacobs saying so long for AM Impact on Your Health.
AM Impact on Your Health is sponsored by Dennis J. Courtney, M.D., Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724